Start, sir.
Good evening to all. This is Chandramohan, ortho physiotherapist from Sri Samraj Physiotherapy Center, Didivanam, Tamil Nadu. A warm welcome to all for the ExRx India's and Sri Samraj Health Services Private Limited's presenting a webathon, a web series, emphasizing for the world record in the field of physiotherapy, not just counting the topics but responsibly providing the knowledge for the physiotherapists in India and 20 other countries. Apart from this, ExRx India is providing online OG consultation for the women's health related issue in association with Peak Health Studio, Chennai, DUSAT Creations, West Bengal, powered by Fitness and Rehab India YouTube channel. ExRx India's 207th topic is Cognitive Behavioral Therapy for Chronic Pain. Will be presented by Dr. Heta Patel. She is pursuing PhD, Assistant Professor Ashok and Rita Patel, Institute of Physiotherapy, Charusat University, Changa, Gujarat. Before I call upon her, I would like to call our today's guest, Dr. Gautam Kumar, who is none other than my classmate in PG, Vanda Gestata Varvan Guest. He's a physiotherapist from RxDX SportsMed, a unit of Rahul Dravid's center from Bengaluru. I welcome my friend Gautam Kumar for this event and request him to have a few words regarding this.
Thank you so much, sir. Good evening to one and all. It is with immense pleasure and privilege I take this opportunity to express my appreciation to Dr. Chandramohan as well as Dr. Rupesh for organizing this webinar series during this lockdown period. The team ExRx come up with this great idea to take the physiotherapy knowledge to next level, which is a great thing, a very innovative idea to share the knowledge from different topics. It's from a basic level of topics as well as to upcoming research level of topics, which is a very great thing for budding physiotherapists as well as those who are practicing currently as a physiotherapist. So they are doing very in India, this is the first time this type of knowledge sharing, which is going on in online series, which is going on there. So a very hats off for both of you and as well as the team which is supporting Professor Duna ma'am. Like they are doing really good job. Hats off for both of you, all of the team. Okay. I would like to welcome Dr. Heta Patel to present the topic cognitive behavior therapy for during chronic pain.
Yes. Dr. Heta Patel, please.
Yeah. Thank you, sir. Thank you, Dr. Gautam, for such a brief introduction about this ExRx. And it's my privilege to have a session with such a gigantic platform of virtual platform of ExRx. So thank you so much for this opportunity, Dr. Chandramohan, Dr. Rupesh, and Professor Duna. Thank you so much.
Welcome.
Yeah.
Welcome. Please start the session.
I'll share my screen. Okay. Is it visible, right, sir?
Yes, ma'am. Please continue.
Okay. Thank you. So today we'll have a discussion on cognitive behavior therapy approach for chronic pain. And nowadays it is very essential component to stop this kind of pain because chronic pain is it is something that is irritates to the patient, and even it will irritate or it will cause a problem in the rehabilitation aspect as well. So by this session we will solve the queries of regarding this cognitive behavior therapy and the chronic pain. So in that, I will be discussing about brief introduction about pain, chronic pain categories and the pain conditions, cognitive behavior therapy concepts, cognitive behavior therapy and chronic pain understanding and its interventions, and the sessions conduction notes, how you can able to cope up with this cognitive behavior therapy in your day-to-day practice as well. And lastly, I will giving you empirical data to show the effectiveness of cognitive behavior therapy and specific field of chronic pain. And even I will be sharing with you a live session of imaginary technique. So let's get started with this. First is now in the next, see, we are very lucky that in the next we will have the world is going to celebrate pain awareness months. So if we have a basic background about this pain and one of the modality, then we can have such a wonderful, we can treat our patients as well. So before moving to that, first we will have an introduction about the pain. Actually, in long back in 1994, IASP, that is International Association for Study of the Pain, has given the definition of the pain, that is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such a damage, right? So all in all, pain is a subjective experience, depends on a self-reported or of an individual. So thus, it is very crucial to distinguish between the pain and the types of pain as well. And for the better understanding and the good prognosis of the treatment, we have to understand the different types of pain. So
This is Carl. In his early
I'll
days,
have an example.
always on the go, driven by a need for speed. He was captivated by planes, trains, and automobiles. His first love? The twin-engine turboprop. The day Carl hit 18, he enlisted in the Air Force. As a fighter pilot, he rocketed off to vast lands and faraway places. He never wanted to leave. When he did, he loved teaching others how to fly and spending time with his nephews. No one could build Model C planes like old Carl. Well, back in the day, before his nephews took that trophy. But lately, Carl's not been feeling like his old self. You see, the nagging pain started in his lower back about 8 years ago. He figured he'd pulled a nerve sitting in cockpits and has been waiting for it to go away. But it's only gotten worse. Carl takes it easy to limit the pain. Most days, he sits on the couch watching old reruns and TV movies. Part of him wishes he could be good old fighting Carl again. But if he got out there, he figures the pain would only get worse. Carl's thoughts about his pain when he's alone affect his mood. He often feels down and on edge. This makes him think about his pain even more. Of course, he's tried to get rid of it, but those pain meds he took for a short time didn't really help and made him drowsy, and surgery is a definite no. But he doesn't know what else he can do. So Carl went to his doctor once more, who recommended he see a pain specialist, Dr. Michael. Dr. Michael helped Carl understand more about pain. He explained that acute or short-term pain is usually caused by tissue damage and goes away within 3 months. But chronic or persistent pain lasts longer, often well after healing has occurred. This is because pain is affected by more than the physical stuff.
Yes. So our friend Oro having has a pain long back 8 years ago, and then how it develops and how it will be causing like a disability, or the person who doesn't have a feeling of to working, so it might be counted as a disability. So it is very difficult to distinguish between the understanding of pain in day-to-day routine our physical therapy setups. So I will brief you about this acute and chronic pain. So acute pain typically can be identified with an incident when an injury is sustained, and such as sprained ankle or supraspinatus tear or ACL injury. So it might be for like less than 3 months, then you can tell that or you can address as an acute pain. And even they are asymptomatic as well. It is adaptive as well, and because it results from a focus of attention on a situation that is treating as well. And acute pain is time limited, diminished with this healing, and even it responds to treatment as well. While on the other hand, chronic pain, So chronic pain, it lasts more than 3 months, then you can state it as a chronic pain. And even then, from the symptoms, it will gradually progress towards the condition, and it may develops after incident and may have a known or unknown cause, because after 3 to 4 months patient might remember those things that I have this incident, and after that I develop pain, right? So it might be reason is known as well, and sometimes it is unknown as well. And lastly, it persists beyond the expected healing time, because it is not only like having this physical disturbances. It might be more than that, might be behavioral or the social disturbances in the patient's overall life. So you can tell, you can quote that it is a quality of life also may change because of this chronic pain. So therefore, the chronic pain is a disease, right? We can count it as a disease, and you have to manage like as like a disease. While acute pain, it you can manage as a symptom as well, right? Now moving towards our today's topic, that is chronic pain. Specifically, we are looking for the chronic pain. So in that, actually chronic pain is a mysterious science of a pain, and it pain lasting beyond normal tissues healing time, right? That is more than 12 weeks, right? General tissue healing time is 12 weeks. So more than 12 weeks, that is more than 3 months, 3 months. So that you can consider as a chronic pain. That was given by Maskey in 2011. And it is very difficult to classify this chronic pain, but most of the time the chronic pain has been classified as when nociceptive pain as well as neuropathic pain. So this nociceptive pain, it is a pain that is caused by damage to a body tissue, and it is based on inputs by specialized nerve cell, that is nociceptors. And nociceptors senses the danger to soft tissues such as muscle, bones, ligaments, and tendons. And even the most nociceptive pain is musculoskeletal, and it is often described as an aching or dull aching type of pain, right? So all the musculoskeletal types of pain that you can classify over here in the nociceptive pain. Next is neuropathic pain. So pain that occurs when there is a nerve damage that typically involves either peripheral or the central nerve, and it is often described as a burning, shooting, tingling, or electrical type of pain. So, if an example, we can take an example of phantom limb pain after amputation, even the neuropathic pain and the this nerve compression pain, radicular pain, that you can quote it over here. So that's a neuropathic pain. Now, where it is a fact, where the chronic pain is a fact, actually it can affect in any part of the body. It is not specific to that this joint is only involved. No, it also involves joints, then muscles, then your skin, then superficial fascia, then your organs are also going to involve. So all the parts, any body parts is going to involve in this chronic pain. Now, I have listed down certain chronic pains conditions. So, in that back pain, in that low back pain, middle and upper back pain, and neck pain. So, chronic pain in that majorly in our India as well, most of the patient having a low back pain. So, according to GDP data as well, the low back pain is the highest pain in the or the first rank in the chronic pain. Even the osteoarthritis, rheumatoid arthritis, gout arthritis, ankylosing spondylitis, all this can be in the chronic pain. Even for the headache, that tension type of headache, migraine, cluster, post-traumatic headache, that all considered as in chronic pain. And in the neuropathic pain, that is neurological pain, that is peripheral neuropathic pain, radicular pain, complex regional pain syndromes, phantom limb pain, fibromyalgia, then pelvic disorders, tendinitis, bursitis, all can consider as in chronic pain conditions. So, but the only one thing is that the pain which is more than 3 months, then it can be considered as a chronic pain. Now, for the treatment options of this chronic pain, there are a variety of treatment options are available, but all the treatment options in the clinical setup, they are being used in a combination therapy as well. So, analgesic medications, invasive options, non-invasive options, and selective psychological approaches, that all can treat this chronic pain, but it should be multidisciplinary approach. So I have listed out certain treatment approach based on that categories. In the analgesic and medication, there is an non-steroidal anti-inflammatory drugs, opioid analgesics, then opioid and antidepressants, muscle relaxants, topical analgesics can be used as an analgesic medications. Then epidural steroid injections, nerve blocks, trigger point injection, facet injections, and lastly the surgery can be used as an invasive options. And then next is for non-invasive options. So physical therapy, in that cold therapy, heart therapy, our exercises, stretching, strengthening, then TENS, then IFT, that all modalities can be used as a non-invasive options. The next, chiropractic, acupuncture, yoga, tai chi have also have a beneficial effects on this chronic pain. And the highest effect is on relaxation training. Also have the relaxation training as a non-invasive option have a can be used as in treatment options for the chronic pain. And moreover, selective psychological approach is in a trending for treating this kind of chronic pain. I will give you a brief about our theories, but first we will have just introduction about this. In that selective psychological approach, there is a cognitive behavior therapy, operant behavioral therapy, acceptance and commitment therapy, that is ACT, and hypnotherapy and mindfulness. That all have their impact on the chronic pain. So it's not just in duty of orthopedician or the physical therapist, it's also duty of the psychotherapist and other parts of our medical field. So for treating the chronic pain, it should be a multidisciplinary approach. So to explain this in a brief, there is in psychological deliberations with the pain theory. Our traditional pain theory, that is in pain gate theory, given by Milzak and Wall gate control theory. In that, it was given in the 1965, and in that model, it was posted that pain signals ascends from a pain and location and can be modulated. So it can be a gate in the brain can be open and closed, right? So thus pain experience can be minimized or exacerbated by attending to a particular stimuli. And here comes the role of psychological factor. So this psychological factor will help in like this gate, like closing and opening. So this psychological factor will help to treat and have this kind of multidisciplinary actions can be implemented based on this theory. Next is about psychological model. In that psychological models, one of the trending use of psychosocial model, in that it is the most useful way to conceptualize and understand of the pain, and even it can be used in a treatment of this pain as well. So it actually work on this biological, social, environmental, and psychological factors that all have a role in the mental health. So it can be used for a well-being of the patient, right? So here comes the role of CBT. So these all factors can be utilized to have a good like treatment approach based on this biopsychosocial model. Next, we will move on the cognitive behavior therapy. So cognitive behavior therapy, here I will be discussing about the basic concepts. Basically, it is an empirical supports and time-limited treatment where a goal-oriented and systematic approach is being used. So it should be systematic-wise. This CBT should be very systematically has to be implemented for the patient, and it should be very careful while you are giving these sessions. CBT is originally developed to treat the depression, anxiety disorders, substance use disorders like medications, overuse of this opioids and all, and bipolar disorders. But now it has been used for a chronic pain as well to treat this kind of patients, but it should be used very precautiously as well. Actually, this cognitive behavioral conceptualization framework will be having this situation, then there will be a behavior, then thought and emotion. So as you can see in the diagram that illustrates, all those factors interact in the bidirectional manner. Specifically, behavior can impact how a person thinks and feel, and thought can impact how a person responds and behave in certain situations. For example, I can take that person having a leg pain and having experience on the standing up from the standing up on a table, right? So that is the situation. Then about the emotion, then it is in a person may feel discouraged and frustrated. Patient might like withdraw that. I cannot be able to do this simple task, right? That's an emotions of the patient. Next is patient will think about that if I try to do anything today, then I'm just going to be hurt more. That's in thought, and based on that thought, that can lead to a recliner in that behavior, that is avoiding the moving for the rest of the day. So that becomes your disability. That becomes then in a prolonged period of time, the role of disability comes, right? Then patient become disabled, right, from this very minimal activities. So here I will give you like one example in that same our Oro friend. So he is thinking that I cannot be able to do. So the whole activity will be ruined by the pain, and having a several kind of thoughts. I cannot be able to do. If I'm going to do, then what people can think, right? And if I'm not be able to do, then how will I will be implemented for my next period, right? So patient will only do that just sit. So this pain cycle, the vicious cycle, will from thought to emotion, emotion to behavior. That vicious cycle will move on for the furthermore. So this kind of situation occurs when patients is having like chronic pain, and they might be like having this kind of behavior pattern will be generated from the patient's mind. Next is about CBT and the chronic pain. Here I'm going to discuss you about with this understanding and the interventions. Now we will have a like in discussion on we had a discussion on chronic pain, and even had a discussion on the cognitive behavior therapy. So how both can be correlated and have the like have can be beneficials. So in that there are the certain influential factors for experiencing the pain. So in the important factors are the psychological factor, then might be behavioral factors, then social factors and biological factors. But in over in CBD, this biological factors can be underpinning the pain condition. So actually, this CBT focuses on patient's thought, beliefs, and behavior, and the social environment. So for the psychological factors, there are total 6 factors will responsible. First is pain cognitions. So negative cognitions and beliefs about the pain can lead to maladaptive or coping, that can lead to exacerbation of the pain, and patients might having increased the suffering of the pain, and that can lead to greater disability. So that's all about pain cognitions, how it will affect on the patient, right? Next is pain catastrophizing. So pain catastrophizing is in thought that or the patient is assuming the worst thing. For example, patient might in assuming that my pain will never stop, right? In actual it will be stop. If it are treating well, then it will be stop, but patient, due to the certain aspects, the patient is thinking that my pain will never end out, I have to live with this pain, and due to that anxiety will more and more, patient might develop the depression as well. Next factor is hurt versus harm. So in that, pain is interpreted and evidence for the further damage, right? Patient is doing such activity that patient might, with the thoughts, patient might become a stand-in. But again, patients start developing pain. Then patients like having an experience that I become a I gain this standing position, and due to that pain, I have a more pain. So it harms me, right? So this kind of hurt versus harm is also one of the psychological factor, and that will give you progression towards the negative effects. So relationship between the pain and negative effect is a complex and bidirectional, as well as individuals with a chronic pain are more likely to experiencing the depressive and anxiety. And and always patients have a tendency to state that negative statements, and it also patient is stating the negative emotions, and and that might lead to increase in the pain. Next is the factor is answer seeking. So patients always having ask patient always ask the like their caregivers or their rehabilitator that if I'm well, if I can be able to do my activities, if I'm returned to my activities. But and this might be the answers of this rehabilitators or the providers or the healthcare persons might be mysterious for them, because we will not ever give that that you will definitely become very regain their activities. So this kind of things can be mysterious for the person, and it might be contributing this psychological factor. Next is pain self-efficacy. So pain self-efficacy is another important and adaptive factor. So it involves the achieving the determining the level of confidence, and then the degree of control also be exerted over the pain experience. So it is one of the most pain important outcome that self-efficacy should be measured, and it is also having the impact on the psychological factor. Next is about the behavioral factors. In the behavioral factors, there are two. It is generally categorized into passive coping and active coping, but other coping as well as they are a part of this behavioral factor. In that, first we will take a look of passive coping. In the passive coping, the guarding. So guarding is like something can be defined as a set of a protective behavior, such as limping and bracing. The patient having pain, right? Then patient might limp, right? If a patient might limp on the same side to show that patient having a pain, or there is a persistence of pain on that specific limb. So this guarding behavior is also then become and gradually it becomes a part of their routine things. If the patient doesn't have pain, but still this habit becoming like causing the habit will develop this behavior, and then patient will start walking like that only, right? Next is resting. So resting for a prolonged period of time, it might causing damage to the like certain up to certain level, right? And this resting is sometimes it is needed, but it is an acute case. But in a chronic pain, resting for a more than a like period, more than a normal defined period, then it will be definitely a problem for the and it might develop the behavioral pattern for if the patient having slight pain, then patient might tends to have a rest. I need rest, right? So this kind of behavior might be possible. Next is underactivity. So in passive coping, underactivity also leads to like behavioral patterns that after that certain period of time, patient might not might change their lifestyle into the sedentary one. So the sedentary lifestyle is one of the factor for chronic pain, right? Then moving towards our second point, that is active coping. So in the active coping, there is exercise, that is exercise having a role in improving the pain, but exercise for a prolonged period of time or the overactivity might be a problematic for a person, right? and it might decreases the or it will be generated the deconditioning of the muscles, or it might be causing harm to the joints, and then gradually they will be a patient might become an like convert into this non-exercise phase, right, or else inactive phase. Next is about recreational activity. So in that recreational activity, the like person might doing the more and more activity that the person is like to do, but overactivity again will cause an harm. So these are the active coping factors. Next is in that other factors, that is pacing. That is again you can consider as in resting for a pacing that I can do for like 1 hour, do the work for a 1 hour, or I can do the work for like 5 to 10 minutes. Then I need a rest. Then I have to take a rest for 10 to 15 minutes. Then I can do the again work. So this kind of mentality also will cause an behavioral factor, right? Contribute to this behavioral factor. And next is about relaxation techniques. So inappropriate or mal use of this relaxation technique is also develops the pattern of this resting pattern. Like patients may like for using this relaxation technique for a prolonged period of time, then patients may become like inactive in their day-to-day activities. Even patients might not be able to do their routine works as well due to this overuse or maluse of relaxation techniques. Next, moving towards our social factors. Okay. So in that social factors, there are two factors in that continuum. First is solicitation significance and the punishing response. So solicitous is like it has been described as an you can say that it is an individual pain or experience of a behavior indicative of pain, and it is highly responsible to an individual pain, and it is less social interaction. So this might patient make herself or himself as in like lone in alone things, right? My patient might be into a loneliness. It will convert it into the loneliness things. Next, so it will be highly this approach is not at all should be, the patient should not go into this approach, right? Because it might be causing a depression. Next is about punishing factor. So this punishing response involves angry or ignoring response, and each will aim at a limiting expressions of the pain, and might be again will convert into stoicism and resignation. So this all factors will lead to this pain vicious cycle, and it will enhance this pain vicious cycle more and more. So basically in this chronic pain cycle, you can see that if you start, it is a vicious cycle as I have described. So first, patient having chronic pain. Due to that pain, first is patient activity is decreasing, then it will develop deconditioning. Then patient having negative emotions that I cannot be able to do. If I'm doing, then what the people other people can assume, or what are the perspectives of other peoples or the society. Then next that will convert into avoidance and the withdrawal of that activity, and that can lead to distress and disability. Distress at the psychological level and disability at the that musculoskeletal level, right? And that will lead to chronic pain. And this cycle, earlier in the beginning phase, it for a one it will be for a one specific task, but then it will be gradually for developing for the rest of the other task as well. So it might progress to your from your recreational activity, then your job activity, then your day-to-day activity, and your routine life as well. So this will cause, this is the whole chronic pain cycle that will gradually develop in the patients of who have suffering of chronic pain more than 3 months, pain more than the 3 months. Next is about chronic pain interventions. So how this will help on how the CBT will help in this chronic pain. So major focus is on the improve the individual's quality of life and functioning across these domains. And for that, there are the common factors of the participants will be that we have to look for, that is presence of chronic pain according to definition and its negative effects on their lives, that you can go through with the assessment and by having the interview with the patient. So this is how you can apply this in the person who are suffering from chronic pain, and you can identify those persons. So in that, there is an CBT model for chronic pain that is actually follows the interaction between the clinical factors in the biopsychosocial understanding of pain, and depicted the interrelations between thoughts, emotions, and behavior are present within the most cognitive behavior model, and various models shows that the chronic pain which adds, and the placement of the pain at the top, it means the reflection it's primary but also bidirectional with all the other life factor, right? So it having social, biological, even the emotional factors, right? All these factors are being served as the in the as the one of factors, contributing factors for the developing the chronic pain. So for the structures of okay. So now we'll have a discussion on the structures and how CBT can be implemented and their sessions. So CBT, for the structure of the treatment of the CBT, that is the overall structures and components and goals of the interventions must be reviewed before jumping towards the treatment sessions. For an individual approach also can be considered, or you can approach the group sessions as well, but it is purely based on the patient or the person or the participants who are involved in this, and their mental status or their health, mental health. Rather than mental status, mental health will be appropriate term. So there are basically 12 sessions in this whole CBT. This 12 sessions has been divided into three categories. First is initial treatment phase, that is sessions of 1 to 3 sessions. Then after that, 4 to 10 sessions will be considered as in cognitive and behavior skill building sessions, and last 2 sessions, that is 11 and 12, that was the discharge phase. So in that total sessions, in the first 3 sessions, the therapist or the therapist must have looked for the assessment and interview, reporting, building. You have to interact with the person, then preparing for the treatment, orientation of to that CBT, and goal setting. So the patients can be confident with this. You have to make the patient confident enough and aware of the treatments, that how the CBT will help you and what are the benefits of it and what are the process the person has to follow. And after that, in that 4 to 10 session, that is cognitive and behavior skill building sessions, in that physical activation and pacing, relaxation technique, pleasant activities, whichever the patient like to do, and cognitive strategies, and even this have a role of sleep as well, because most of the time patient having irritability and the sleep, or patient might having suffering from insomnia. So this component must be included while we are treating this kind of chronic pain patients. And at last, there will be a session of discharge phase, that 11 and 12. So 11 session will maintaining of the treatment gains and anticipating obstacles while whole treatment. What are the obstacles patients might having suffering? And lastly, the discharge plan on the and the last session for the booster session, that is for the to have the motivation to that patient and the follow-up session. So all these aspects of the sessions. Now we will have a more discussion in detail about each sessions, about this agenda, or how to deal with that, and what are the materials you need, that we will discuss in this next section. So who are the ideal participants? As we have seen that the person who are suffering from the chronic pain, they are the ideal participants. But more in that aspects, some more brief about it. That is the person who having the psychological condition, and in that first criteria, that participants benefited from the additional coping skills to self-managing pain maximally, right? Second is participant is not progressing as expected with indicated medical treatments. They are also can be a can be a participants. Then participants presence with a negative exaggerated emotional and behavioral reactions to the pain. So these patients are the ideal patients for delivering the cognitive behavior therapy in them. Apart from this, there are no contraindications for the disease treatment, but the sessions has to be in a continuous mode. There should not be any break. If at all, then the session should be started again with the first thing. If at all break in the third or fourth session, then the session should be started from the first again, because it might lead to because already patient is suffering from the psychological condition, so this might be increasing the conditioning. And it is also ideal for the patients who are taking the large number of opioids or analgesics. Next is guidelines for the participant selections that should be followed by the therapist, that are the patients who are having the chronic pain condition that should be identified. Then patients who are having the experience of pain related impairments in various domains of functioning, that also should be identified and assessed. Next is person doesn't report current or significant symptoms of psychosis or mania such that is impedes ability to follow the structure of content of CBT. So that should be well aware in the past history of this patient while assessment. And person is able to engage in some form of physical rehabilitation, right? So by the mean, that is bedridden patient cannot be part of this, because we are having in the second session, we are having the pacing and exercise. So if the patient is not involved in that, then it cannot be benefited for them. Yeah, but you can take it is not always like physical rehabilitation, but you can also implement in them with the bed mobility exercises. But patient must do that things and properly obey those things. And here you also have to look for the health the care providers as well, because care providers perspective also a mandatory aspect in this cognitive behavior therapy. So major objectives of this behavioral therapy is reducing the negative impacts of pain on a daily life. Second is improving the physical and emotional functioning. Third component, increasing the effective coping skills for managing the pain. And fourth is reducing the pain intensity. So all this can be your major objective, and the therapist must have to set down as in goals. As in this objective should be considered while treatment as well. throughout the treatment. Now moving towards so far, any person having any doubt? If not, then we shall move further on about the sessions of practical sessions.
We will move further, madam. We will have the doubt session later.
Okay, sir. So in this practical sessions, that is one of the crucial, and you have to handle it very precautiously as well. So in this session, in these sessions, first we will have in the first phase, that is an initial treatment phase. First is interview and assessment. So that will be clinical pain evaluation and baseline assessment measure. And second will be CBT-CP orientation, that pain education and familiarize with the CBT-CP approach to the treatment, right? So in that, all the things which I have explained you in the previous things, that CBT model, chronic pain model, then chronic pain cycle, that all you have to explain to that patient. Then third is assessment, feedback, and goals planning. In that, the person, in that, the clinical implications of assessments and development of the treatment goal should be set it out. And you have to plan, and that plan must be discussed with your patients. So in first is interview and assessment. So major agenda for the therapist to set it out, that is first thing is conduct the clinical interview, and this interview might be a face-to-face interview, or it can be recorded as well, or by sending the mail as well. But that should be the person should be interviewed in a proper, rightly manner. So to gain the positive feedbacks from the patient. Next is have a participants complete assessment measure, and in that complete assessment measure, the person might need of CBT-CP form that will consist of demographic data, pain history, current medications, past history of like whether the patient is suffering from mania or not, psychosis, mania kind of conditions. Then area of functional impairments, that all should be included in the CBT-CP form, and this should be this printout should be there while you are interviewing to this kind of participants. Even for the assessment aspect, the pain measurement scales that for the objective measures should be there, that are NPR, this numerical pain rating scales, then sorry, wait for a while. Okay, fine. Numerical pain rating scales, then there should be PCS, then PHQs, then WHO QLB, then suits, that all things should be there should be considered as an objective measures. And the third objectives should be like third things is to discuss the next plan, and even the therapist must have to contact the care providers. So in that aspects, these are the materials you need, and the third material you need, that is communication with the primary care providers. Again, with that is also with the face-to-face discussions or the electronic recordings or the sending an emails, so that it can be presented as an evidence for the care providers. Next is the second session is treatment orientations. So in the treatment orientations, the agenda will be set out to administer the subjective units for the distress scale. Then establish the agendas and ensure all the measures from the previous sessions are completed. And fourth will be present the session 2 content and explanation of the CBT, and ask the participant to complete the VSR scale at the session conclusion. So in that, it is actually purely based on the patient education. The therapist must have to brief about the concepts and the treatment. So material needed over here is CBT-CP model handouts, chronic pain cycle handouts, and factors that affects the pain that can be considered in the form of biopsychosocial model. This whole like figure can be taken as in consideration. So that's all about the second session. So in that second session, again, the treatment initiation assessments. So how you can start the asking to the patient, and the following questions can be determined for the interest of the participants for the further session. So in that, based on what you have learned, do you think that this treatment may be a good fit for you? Next is, if you have any reservations about the participation thing, then what are they? Then you have to answer this whole thing, all the things, and make the patients like unquestioned. Like patients should not be questioned. So should not have the further questions. All questions should be answered and in a well mannered. Then third will be, do you feel ready to take a more active approach to managing your chronic pain? Then you must have to ask that, do you have any other questions that you would like answer regarding this CBT-CP? Because it is very necessary for the further things, because already patient having more and more questions, and already patients went off to several doctors, several therapists, several patient has tried several things for to reduce those pain, but all those are not effective. uh, like patient feels that all those are not effective. Then uh, at this point of time, the all the questions from the patients should be addressed in a well manner. It is mandatory to get the positive aspects for the further sessions. uh, then moving towards the third session, that is assessment, feedback, and goal settings. So agenda for that sessions are administer the subjective units for the distress scale, establishing those agendas, reviews the sessions, and present the session third content for the content of the third sessions, and that is assessment, feedback, and the goal planning, and discuss the home practice for the SMART. So now, what is SMART model? That is specific. SMART stands for specific, that is identifies the specific actions or the events when the pain starts. Second is measurable. The pain should be measurable with like using those objective pain scales, and it should be quantifiable so that progression can be tracked. Third is achievable. So in achievable, it should be attainable and realistic given source. So it should not be like if a patient is like thinking that I would have to stand, then you have to give the patient wants to be stand, then you must have to give the task of standing oriented only. Then you don't have to dream out for the you can run as well, right? You have to run. That things should not be incorporated in the initial phase. Based on it should be the goal has been decided, that should be achievable only. Then the fourth will be relevant, and all the further sessions should be relevant as well, and it should be meaningful. Patient want to stand, then ask the patient to stand only. Like then you don't have to hurry on and move on, jump on to the patient's sports activity or the recreational activities. So it should be relevant to that condition as well, right? In another way, if the patient is suffering from low back pain, then patients might the things are relevant to the patient, that is sit to stand, walking, and all. Then you don't have to like further move on to the running and all. Next is time bounded. Time must be a factor that should be consideration for the further things. And the goals must be based on the timings only. It should be time bounded. The second will be cognitive behavioral skills building. That is 4 to 10 session. In the fourth session, the exercise and pacing, it will shows the importance of movement and thoughtful approach to the physical activities. Fifth will be relaxation and training. That is relaxation benefits and its techniques as well. Then pleasant activity 1. The sixth session will be for that. That is for, to identify of meaningful pleasant activities. That is the which gives the most of the joy and pleasure to the patient. Then the seventh will be pleasant activity 2. That is implementation of selected enjoyable activities. Then in the eighth one, that is cognitive coping 1. Over here, the role of active coping will be there. Their behavioral patterns can be changed by this thing, and with this, to understand the automatic negative thoughts and how they will impact on the pain experience. And in the ninth session will be cognitive coping 2. That is monitor and challenging the automatic thoughts. You have to move on further into the next step of activity level. And the 10th will be sleep. That is strategy to improve the sleep despite pain. So we will have a brief discussion about these sessions. So for in the second phase, the first that is the fourth session of with your participants, and then exercise and pacing. So agenda for this, that is administer the subjective unit of distress scale, right? That scale will tell you the further progression after the first session, and you have to compare that stress with your previous scale as well. Next is establish the agenda, that what you are going to plan and all. Next, and that should be discussed with your patient. Then third is in this session you have to review the session 3 as well and present the session 4th content, that is hurt versus harm funda, exercise programs, and time-based pacing. So hurt versus harm funda over here will help you out to see the patient's thoughts, what the patient is thinking for the for their activities, limited activities. And lastly, the person must have to discuss the home practice for the exercise pacing. See, in all this second phase, practice is must mandatory, and you have to explain in such a way that without practice, this therapy will not help you at all. So for that as well, you have to give such an task or such an table kind of things to the patient to note it down, right? And all these things should be monitored and observed. Next is about materials. So here the education of the chronic pain cycle is must necessary to explain the patient where there is a role of behavioral therapy, behavior and social, have it be converted from the physical thing to those components. And over here the material should be provided, that is material should be should have, that is chronic pain cycle handouts. In that, hurt versus harm explanation must be there. Then walking log with the, as you are introducing this some activities. So first the person should start with the walking. So that walking log with approval from the care provider must be there. And that walking log will describe about the how much patient can able to walk, right? And even there should be a pacing activity worksheet should be there. And this pacing activity worksheet will tell you, give an idea of, that should be that should be given or allotted to this patients, so that will be giving how the patient is, how much frequently the patient is taking the rest. So that will be that you can the therapist can have an idea about it. The fifth, that is relaxation technique. Relaxation technique is one of the most and wonderful technique that will help to the patient. And that see over here you can use recoption technique and several other techniques that we are using in our field, right? So that you can introduce over here, but clear-cut instructions must be needed. And for agenda for this fifth session is administered again, same as continuation, administer the subjective units for distress scale. So by administering this, you can have how idea about how much stress patients still have with this fifth session, before this fifth session. Then establish the agenda, what you are going to do and how you are going to explain, and everything should be clear cut and well defined. Then it is must compulsory to have the review of the fourth session, and even it is important and to have the content, you have to present the content of the fifth session, and in that relaxation rationale, that all the research, how there is what are the effects of it, and what are the strategies can be implemented, and which techniques you are going to use, and how you have to use it, and even you have to give the home-based protocol for that as well. And lastly, discuss the home practice and ask to complete the VSR at the session conclusion. This must be completed. In that, materials is relaxation. So based on that, materials are needed, that is relaxation benefits and tips handouts. It is used for the relaxation app. You can also give the relaxation applications which are available on the Android phones, right? Even it is available on the Apple phones as well. But then you can ask them to pair the activity, and even that can be instructed to this care providers at home as well. And even ask them to select the mantras, that is I have to I have to be fit and fine, and I can be fit and fine soon, right? This kind of things, so that it will provide the motivation to the patients. Then you can introduce for the relaxation deep breathing exercises. Then slowly, gradually, you have to teach this deep breathing exercises, so it has a wonderful control over their psychological thoughts. And then after that, progressive muscle relaxations, that should be started with the major muscle group, and that should be noted out as well in the pen and paper kind of thing, right? And then it should be guided imaginary technique also must be introduced and implemented for having if the patient is mentally imagining something, then that will be that will foster a relaxed state. So with this aim, guided imaginary technique should be used. And the last even this all things should be in the record. The person should record these things, that how much session, what are the responses of the patients and all, right? And lastly, ask the patient to complete this walking allowance inventory short revised scale at home. That should be ready from the home with that you have to deliver as the patient allotted. This work should be allotted as in home session, and that must be completed for before moving to the next session. Next is about pleasant activity 1. So agenda for that is administer the subjective unit for the distress scale, establish the agendas, then reviews the 5th session and do the visualization exercises, and then present this 6th session and exploring the pleasant activities as well. And same, it should be discussed for the home practice as well. So this pleasant activity, in this phase, the person must to identify from their basic work that which are the activities gives a pleasant, and this based on that you can move on to further session. So what are the benefits of this pleasant activities? That is positive distraction from the pain. Patient might feel that I am, or now I am moving towards the good, my prognosis is becoming good, right? Then next is improving the mood and the self-esteem. It will also increase the socialization as well, because Now patient having a confident in their activities. Next is enhance attention and concentration on the skills that will help for coping up the further sessions of the coping, and enhance a sense of purpose and directions. For this, the materials has should be used, that is guided imaginary handouts and pleasant activity list that should be should with the therapist. Seventh session, that is in pleasant activity 2. Agenda for this, that is participants completes the assessment measures. Whole assessment measures should be completed before moving to this session. Then establish the agendas in a very clear manner again. Then revise the session 6 if it is appropriate or for the patient, or patient is happy with that or not. Then present the then in this present the session 7th content, that is establishing and scheduling the pleasant activities. So which activities you can plan for the patients, and these activities must be incorporated in the home programs. So materials for this session is all assessment measures which has been taken priorly, same assessment measure, that NPRS and all, that should be taken over here again. With that, inventory scales as well, activity inventory scales as well. Then pleasant activity list should be ready. That ready list from the 6th session should be with the patient, with the therapist, so that it can be based on this, the therapist can guide for the further activities. And next, and the third one is pleasant activity schedule should be there. So schedule means in the whole day, which type of activity the patient must be do, and how much time and the frequency should be noted out in a proper manner. Next is about cognitive coping 1, that is the 8th session for the agenda for that. That is again, now over here, you have to administer the suits, that is subjective units of distress scale. So then with this patient, you have an idea about how much the stress is reduced. Then you have to establish the agendas for the sessions, reviews the session 7th, and present the session 8th content. In that, recognition and monitoring of negative thoughts should be must be monitored by the patient, and there are the several questions that from the therapist you have to ask, and again discuss the home practice and ask to complete the VSR, that inventory scales for the session conclusion. In this, materials being used, that is patient's thoughts handouts, right? In this, patient might be like use give you have to give to the patient, and patient might be in a drawing form or in a writing form that should be interpreted in a well manner, and catching the automatic negative thoughts from the worksheets and then you have to ask the patient for the self monitoring of the thought, and again work alliance inventory short revise should be completed, and that should be as in material. Next session is about the cognitive coping 2. So over here, the role of exercise will come, right? So in this, active coping must be there, and for that, again, administrator the suits, establishing this agendas, review the 8th session, present the session 9 content, that is challenging negative thoughts, how the patients can challenge those thoughts, and discuss the home practice. So for this, patients, the therapist must include these questions. Is this 100% true that you can able to do or not? Is there is a different way to look at this issue? Like for the negative aspects, you can ask them. There are certain other aspects as well. Even you can show during the session, you can show that lion's picture, that on the one side and the other side. Like on the one side, a lion shows that he caught his baby, but on the other side he is saving his baby, right? So that picture, that kind of imaginary things you can take them help to have to broaden up the perspective of the patient about these issues. And then what would I tell a close friend if they had these thoughts, right? So this kind of things should be incorporating. Is this thoughts helpful for the patient or not? That should be like you have to ask these things, repeat it again and again during the sessions. And if there is evidence that the patient is not taking into account, then you have to note down it and you have to coping that activity in the next 10th coping session. So what materials can be used? That is catching automatic negative thoughts worksheet and the coping statement checklist. Next is about sleeping. The next is about the sleeping and sleeping, right? So the sleep is a common complaint for the patients who are suffering from pain, and that can be quoted as an insomnia. So most of the time, this has been in the research as well. It has been published that insomnia is a major symptoms for the chronic pain patients. So the cognitive behavior therapy is also gives a hands in this. So in that, the agendas for that is administer the subjective unit distress scale and even insomnia severity scales before up this session. Then establish these agendas and for the clear cut view, review the session 9, which other details has been left out or that should be incorporating in the sessions, and present the session 10 content, that is chronic pain and sleep education and the approaches. So over here in this sleep education, the person should give about the sleep hygiene and all, the introduction about the sleep hygiene and how it will be coping up and how the patient can have a effects on their routines and all, and discuss the home practice. Materials that are insomnia and severity index scale can be used. Even sleep hygiene checklist can be used. Sleep behavior change log also can be used. Then for this, stimulus control instructions should be given, that is only go bed while the patient is feeling sleepy, use the bed only for sleep only. If unable to sleep for after 20 minutes, then get out from the bed and do the activities which you like. Then return only when patient you are feeling sleepy. Then wake at the same time every day. There should no biological sleep should not be any interference in between that. Then even you can ask the patient, do not nap and maintain the sleep hygiene, that are environment, clock watching, and stress and relaxation. So for environment, you can ask to choose as the patient to choose the minimal noise and appropriate light environment, and the temperature should be well maintained in that environment. That can be used typically to control this factor. And for the clock watching, avoid watching clock and continue down the timings, because most of the time when the patient is suffering from insomnia, then patients are always having that 1 hour, still I don't have sleep, still I don't have sleep. So this kind of that clock should, even you can ask the patient, remove the clock from your bedrooms. Then remember to get out from the bed if you are unable to sleep. So that will handle the clock watching activities. Then for the stress, worries can be resolved with the that coping and thought effects. And lastly, the relaxation. So in that technique, the person has to acquire specific techniques to reduce the tension and initiate the sleeps. So this is and this relaxation is one of the new technique for having this kind of in the sleep, right, to have the sleep. Next is a discharging phase, that is 11-12 phase. We are moving towards our last sessions only, so be patient in that. Last is discharge and planning. So in the discharge and planning phase, plan for the flare-ups and review of the CBT-CP skills. So how the patient is progressed from the first to last, and you have to show in between that you have taken the suits and all the intervention scales, that you have to show the difference to this patient. And in the 12th session, that is a booster session, that is evaluate and implementation of the CBT-CP skills. So this discharge phase, in that most of the patients are recovered from that behavioral and social component and even psychological components. So patient is giving you a positive feedbacks about these sessions. So discharge planning agendas are participant completes the assessment measures, establish agendas, then review sessions 10 and present the session 11 content, that is anticipating and discharge planning, and the reviewing the overall goals. So in that overall goals, majorly patients should ask for the emotional stress, weather changes, and lack of sleep. That should be more concentrative aspects should be for this kind of patients. And materials should be in use, that is all assessment measures, anticipating obstacles, worksheets, and weekly activity schedule should be there. In this anticipating obstacle worksheet, that you have to ask which are the content, which are the things that is still obstacle for you. Then you can again plan out for this same technique at the individual level. Now, asking the patients for such questions to facilitate the discussions for this session and help the participant they identify their own progress. So for this, you can have you become a more active? Has your mood improved? Do you feel like your life is more fulfilling? And even though you still have a pain, are you accomplished more? Have you noticed a difference in your pain intensity? And what about your react to your pain? So this kind of things might lead to a positive impact on the patient, and patient might will have the better effects. So patient might describe in a brief way as well, rather than giving a one line question, and expect from the question patients to have a brief description about all these questions. Next is booster session. That session is implemented for motivating patients, and furthermore continuing with this the further sessions, continuing with the sessions at the home. And this booster sessions is based on should be selected based on the individual needs. And for that, agenda should be administered the subjective unit distress scale that was for the last time, and discuss the current functioning and progression, and give them like you just have to give the assurity that you can do better and well with this, and review the CBT-CP model. And again, you have to this handout should be provided to the patient, and whenever the patient is feeling that I cannot be able to do same kind of feeling and the previous one, then the CBT-CP model can be helped to the patient to motivate and to have the to go up to the next level. Next, and then the next agenda will be troubleshooting, that present the appropriate content, right? And discuss the future plans. So for this, there are material should be CP model, that over here you have to give to the patient this handout, and future plan worksheet also you should be with a sign from the care providers and the patient, you have to give to the patients. And that should be made very easily and understanding way with the day wise. And for that, you can ask to the patient for felicitating this discussion, that what has gone well, why have you those things work, what has not gone well, then what are the specific problems you have faced during this, then what you have been the biggest barrier in implementation of the skill that you have learned, and in this area where you have been successful, and you have to highlight in those successful area, and give an appropriate way to think on it, and why have you been successful, right? By asking such kind of questions, you can do this. So that's all about the overall 12 session, and these are the list which you need while looking, if you are looking for giving the CBT, then it is must needed. These things should be priorly with you, and based on that you can plan out for your further goals. So there are several studies in this have quoted. There are several and numerous studies which has been found out on a good you can find out in a PubMed and a good index journals and even in the Cochrane as well. But here I have listed down certain the studies in the recent year only that is which shows the effectiveness of this program. So there are inserting from a systematic review from this randomized control trial, even the case series also been reported and the reviews are also been reported, right? So I think this thing will help you to find out your question of the research question from this understanding, and you can phrase on it and you can work on this direction, and it is a very trending and emerging branch for our physiotherapy field. So you must have a look by this data will help you. You must have a look into this, and you can find out the metaphors of these articles, and based on that you can move for and you can plan for your future research as well. So this is one of the thing for improving the CBT for the chronic pain patients. If you want, then you can have this video for imaginary guided technique. So if possible, then you can we can have this session for 5 minutes. Yes, Chandramohan sir, can we further move
Yes.
further?
Yes, yes.
Continue,
Okay.
ma'am.
Fine. So this session is something live session. Now everybody kindly close your eyes and take a deep breath, and this whole thing will guide you.
This 5-minute meditation can reduce nervousness before events, such as interviews, beginning a new job or school, or dealing with everyday stressful situations, or just whenever you want to feel calm. To begin, sit on a chair with your feet on the floor. Inhale through your nose to the count of 4, then exhale through your mouth to the count of 2. Do this several times. Imagine that rising from the core of the earth up to your feet comes a sphere of white light. Concentrate on it. Draw it through the soles of your feet. Feel its warmth as it enters your body. Feel it sink into each muscle, into every fiber. Continue to draw it upward through your calves, knees, thighs. Feel it dissolve stress and tension as if you were sitting in a warm bath. Let it flow on upward to your solar plexus and disperse tightness. Feel it bathe your upper back, your throat. It illuminates your face like sunlight, ridding you of any tension in your head. warmth infuses you with calm and with confidence. Say to yourself, I am calm. I am centered. I am at peace. Now imagine the light returning to the area of your solar plexus, the seat of your emotions. From there, it radiates out through your skin, flowing down from your head to your heels and surrounding you with a protective aura.
Okay. So that's all about this session. And see, this imaginary guided technique will also help you. It is like something is not, it will help you to stress out from your day-to-day routine as well. And you can use this kind of techniques even if you are not suffering from pain. Like that, but that's all. If you have any queries, then you can ask.
Thank you, Heta madam, for a wonderful session. Let's move on to the question and answer session. Dear participants, if you have any queries, please write on chat box or you can unmute and ask our resource person. Those who are watching in Fitness and Rehab India YouTube channel, please write the queries in the live chat box. We will read it out here.
Questions here, sir.
Madam?
No questions yet, sir.
Yes, please.
No questions yet have come, sir.
Is there any question?
No questions yet have come, sir.
I cannot hear you properly.
Okay, ma'am.
Rupesh,
I understood. Yeah, I'll take care, sir. Participants, any questions in your minds? You can place it in your chat box or unmute yourself. Alagappan sir wants to ask.
Yes, please.
Ma'am, sir. Alagappan sir, you can unmute yourself, sir.
Oh, hi. Hi, Heta ma'am. Ma'am, thank you for the wonderful presentation. Am I audible, sir? Yeah?
Yes, sir.
Rupesh, sir, am I audible?
Yes,
Yes.
sir. Sir.
Heta ma'am, thank you for the wonderful presentation. I have two questions, ma'am.
Yes.
Cognitive behavioral therapy is like widely getting recognized in chronic pain management. I've come across a lot of articles at recent times. And
Yes.
even like Professor Arivam sir, Prakash sir, we all like, when we discuss, they have been working extensively with CBT.
Yes.
My thing is, what is the set point? See, at beyond what point you can refer to a psychologist or a psychiatrist with your patient? Say, for example, you have recommended a 15 days of session, ma'am.
Yes, sir.
Let's take it out like someone with periarthritis shoulder who is suffering for 1 year, who doesn't have an understanding of how to progress it further, even if he meets a good expert physiotherapist or a doctor, how you will proceed with him, ma'am? At what point we can refer the patient to a psychiatrist?
Sir, in that, the person who are having more than 3 months of chronic pain, right? So in that cases that you have mentioned that 1 year of like patient having one
Yes.
year of this periarthritis of shoulder, right? So
Yes.
if the patient is denying for doing like physically patient can able to do, right? Even
Yes,
if
ma'am.
in our assessment as well, you cannot find anything wrong in their like joints or the structures,
Yes.
the things that then with that patient, but patient is feeling that I cannot be able to do. So with
Okay.
those patients can be send it to this psychiatrist for the
Okay.
further sessions. So for that, you
Okay.
have to identify based on the scales which we are using. That's super
Okay.
scale and that pain scales.
All right, ma'am. My another question is, how far fear factor gets control with CBT, ma'am?
Fear factor,
Generally, say for example, I used to work more with fear avoidance belief questionnaire with my patients.
Okay.
Because it involves like when they are with chronic pace, we need to work on with fear avoid belief.
So
Yes.
in that cases, most of the fear avoidance, like patients, if the patients are adaptive, having the behavior, they having the changes in their behaviors, then you can like move on and further progress on this.
Okay, ma'am. Okay. Thank you, ma'am. Thanks a lot, ma'am.
Welcome, sir.
Thank you, sir. And few appreciations are there. Any questions and queries, dear participants? Anything in YouTube, Duna ma'am?
No questions in YouTube yet.
Yeah, ma'am.
Okay, we will conclude it now then.
Okay, sir. Just a minute.
Yes, Rupesh,
Yeah, sir.
please stop screen sharing now.
Thank you so much,
Thank
and
you.
all the best, guys, for your world record.
Thank you very much.
Thank you so much, madam. And I would like to thank today's guest, my friend Gautam Kumar. Are you there?
Yes, sir.
Yes,
Yeah.
I'm here.
Yes, yes. Thank you for your presence, Gautam. We are happy to have you.
Thank you so much,
And
sir.
yes,
Thank you
like
so much, and
the
thank you.
ExRx India trio, we were the three persons in our PG classes, roaming here and there, spend time together,
Exactly.
and after a very long time, we sat
Yes,
together for
together.
a long time in this session.
Long time.
Actually.
That's
Yes,
really.
yes. Thanks for
That's
being
true.
with us, and I wish you all
Yes.
success in your future also. You must
Thank you.
also
Thank you.
go further. Okay.
Thank you
And
so
I
much
didn't
for
want
giving
to
this opportunity.
in this event. I expected you to present a topic, but due to
Sure.
your unavoidable circumstances, you couldn't make it. But that's why I wanted you as a guest. We didn't want you
That's
to
my
miss
pleasure.
in this event, whole event.
Yes, sir.
And
Yes,
thank you so much. And I thank Dr. Hita Patel for a very wonderful session. Actually, I was a little bit hesitant because I don't know everything about her, and she made my day. Actually, I can say that because pardon, madam.
Like the session was more beyond the time, more beyond the 1 hour, but the content was so like I have brief out those things. But when you are applying to the patient, then it will be wonderful experience you have.
Yes, madam. Thank you so much for a wonderful session. Actually, I don't know how much you have collected all the details, and CBT is a very extensive topic.
Yes, sir.
And there are legends who are talking for 4 hours, 6 hours regarding these topics. So you made it in a nutshell, all the questionnaires you have collected, and the way you explained, and even you played two videos. Everything is very fine, and the video also played well actually.
Yes, sir.
No breaks or no stop in the flow of it. Okay. Thank you for your wonderful work. And I thank ExRx India team members, Dr. Rupesh and Professor Duna Madam. And I thank all the participants who are present in Zoom meeting and those who are watching it in Fitness and Rehab India YouTube channel. Big thank you for all. Good night to all. Bye-bye.
Bye, sir.